Great. I think it's good evening, everybody. I'm in New Hampshire, and one of the big passions I have is geriatric and palliative care integration. I'm really happy to see this crowd because, very rarely we combine palliative and geriatrics. I think it is lacking, and I think we need a lot more help with geriatrics in India and all over the world. I have no financial or industrial relationships to report. Here are the objectives. Yeah, I would request if anybody who's not talking, stick in mute, just so that I can. Thank you. So the objectives here are to discuss the significance of integrating geriatrics and palliative care, understand the 5M principles in the care of older adults, and to create evidence-based approach in diagnosis and management of geriatric conditions. So the word geriatrics really came from actually the word geron and old man in Latin, and coined in Sinai, where I did my fellowship. And also it's about a healer, and there is no defined age according to United Nations, but in the US it is, and CDC, it is 65 years. Mostly all over the world, above 65 is considered geriatrics. Now, why is this important? Because the world is aging at a very rapid rate. So in 2030, it is expected to have 34 nations which will have more than 20% population above 65 years. And also in 13.1% in India by 2030, and in USA expected to increase up to 20%. It's pretty large number, actually, the way it's increasing. And so we really have to know how to deal with older adults. A lot of older adults end up with palliative care, so it is important to have or understand the integration. The life expectancy in India is about 67 years in 2021, and in US about 76. There is a pretty big gap, but I think, in my opinion, we should count geriatrics in India above 60 years just because of that life expectancy difference. Now, why is this important? Here is a very good picture about an integration of geriatrics and palliative. Okay, so we start with screening of the condition. You then diagnose the condition. You see if there is a curative nature of the condition, and then the patient, if there is a serious illness, it starts getting very serious, and that's when you introduce palliative care. When it comes close to end of life, which is basically prognosis of 6 months, then we start talking about increasing frailty, hospitalization, they become more debilitated, and they start having decreased quality of life. This is how the graph looks. So as I said, how and why to integrate, mainly to meet the complexity. So what happens is in geriatrics is that they've had like 20 or 30 diagnoses by the time they reach that age. So it's extremely complex, the things that they're going through. So they also need help with shared decision making, right? Like at that age, sometimes you need help from family, from the children, or we need help to make decision making, and also we need a seamless transition to the community, right? Because the patient may not know the resources available in the community, and the patient needs more help at that age. Overall, also reduces the hospitalization. So if the patient is able to tell us, I don't want to go to the hospital, I don't want to get admitted to the hospital, or is able to give their wishes known in advance, it reduces the, emergency medicine, emergency hospital visits, and also maximizes the quality of life in older adults. It also addresses caregiver burden and improves overall patient and family satisfaction. So when to initiate this? So there are markers in geriatrics for palliative. Okay, so there are disease-independent markers and disease-specific markers. The disease-independent markers are like frailty. Frailty means what? Basically overall weakness and overall functional decline, where they're requiring more and more help. So functional dependency on activities of daily living. Cognitive impairment means basically, there's a decrease in the function there, and also symptom distress, family support. So these are disease independent markers, meaning no matter what the diseases are, these are the markers. Whereas specific diseases like congestive heart failure, chronic lung disease, dementia, stroke, cancer, infections, hospitalizations, chronic pain, functional impairment, these are patients where are specific to diseases. The prognosis changes based on the condition, and that's why it's called disease-specific markers. What is normal in aging? A lot of people say, I forgot my keys. Doc, am I having dementia? So that's a real question, right? So we'll get to that. But what is normal is, so in each organ, there is a change as patients get older. So for example, when there is, the brain, we have start decreasing axons, decreasing, the neurotransmitters start getting slower. With the cardiovascular, they have decreased artery compliance, right? So they have higher, incidence of hypertension, of strokes. In lungs, they have decreased lung volume or decreased exercise tolerance. In kidney, they start having chronic kidney disease because of long-standing high blood pressure, heart failure, congestive, and hypertension. For bladders, they have urinary retention, incontinence, musculoskeletal, high risk of falls, osteoarthritis. Vision, they have presbyopia. Auditory, they can have presbycusis, which is basically all sensory neural hearing loss. So this is actually, all of this is considered normal part of aging. Now here I want to introduce, this is the main point of this entire course and entire presentation, and I hope that by the end of the presentation, we have an idea on how to use the Geriatrics 5Ms. And this is the hand picture that is from American Geriatric Society, which I hope, can be useful in every aspect of our lives with geriatric patients. So the first one is mind. So I can go all five. Mind, mobility, medications, what matters most, and then multi-complexity, which combines all the four. So we're going to talk about mind first. So what comes under mind? So mind would be dementia, delirium, depression, and how to assess mentation. So I'm going to make it a little bit interactive. Can someone tell me, I'm sorry, 1 second, I need to go back. What is the definition of, what does everybody think dementia is? Is there anybody who wants to answer that?
Chronic depression, it's a chronic issue, and over the ages, your remembrance, your activities of daily living become tough.
So definitely it is chronic. Also, there is a decline in one or more cognitive domains, which include language learning, memory, complex attention, executive. The biggest point here is that it affects your daily life. So the patient that tells you, doc, I forgot my keys, or doc, I'm forgetting here, there, is it affecting your daily life? If it's not affecting your daily life, it is not dementia, So that's what we need to realize here is the meaning of dementia. And also there is something called ageism, where you look at a 90-year-old person and they think that they have dementia, but there are some healthy 90-year-old patients who actually have perfect cognitive status, maybe very mild. So we really have to be careful when we use the word dementia. So there are different types of dementia. So there is, most common is Alzheimer's disease, which is mainly affects the memory, especially short-term memory. Vascular is when you have a stepwise decline, and stepwise decline means like they're fine for 6 months and then suddenly deteriorate, and then again fine for like a few months and then again suddenly deteriorate. So it's like a very drastic decline one by one, and it's very obvious. That's the vascular. Mostly for patients with like heart failure, atrial fibrillation, those come under the vascular dementia. Parkinson's, we know they will have the Parkinson's syndrome, they will have the, shuffling gait, we all know as doctors, we've learned what the signs of Parkinson's are, including like faces, the tremors, the resting tremor, all of that. Lewy body dementia is visual. So when, it's very similar to Parkinson's, but it's not exactly the same. In Lewy body dementia, there has to be visual hallucinations. It's very important in order to categorize that. Then there's frontotemporal, which is also Pick's disease, which is behavioral. Most of them have extreme behavioral issues, and that is more towards frontotemporal, also in younger patients. Now, yes, that dementia is chronic, but there are some reversible forms of dementia, which are vitamin B12, medications. So when I say medications, when patient is using the medication for the last 3-4 months and presenting like dementia, you take the medication off, and then reassess and see if the cognitive status changes or not. So that is a reversible form. Irreversible is things like Alzheimer's. Once it starts progressing, that's about it. There's no more changes there. Difference between dementia and mild cognitive impairment. So I hope you understand. So difference basically is whether it affects the daily life or not. Mild cognitive impairment does not affect daily life. What is the difference between dementia and delirium? Can anyone give me an idea if anybody knows what's the difference between dementia and delirium?
Delirium is acute, dementia is chronic. Delirium, you can get differences. Morning, you are okay, by afternoon, you are bad, evening, again, you are okay. And delirium has got some underlying medical issues, most probably.
So definitely delirium is, different types. We'll get into delirium also, but it is acute. And so, if somebody says, I have, my father, there's a change in his mental status for the last 3 days, that is delirium. But if he's been having behavioral disturbances for the last 6 months, that is more towards dementia. Okay, so the dementia patients are the ones who have sundowning, and delirium is more with medical issues. There's something else going on. You can screen every once, whenever the patient comes to the primary care, once a year at least, they should be screened for dementia. So what are the functional abilities? Here we have activities of daily living, and then you have the instrumental activities of daily living. So if they have dementia, what is the first thing? I don't know if anybody can think about this and say, like, what is the first thing that will go in IADL? Or in other words, what is the hardest thing to do among the IADLs?
Handling finances?
Yes, exactly. That's great. Yes. So handling finances requires a lot of complexity. It requires, calculation, it requires a lot of, so it basically requires all the IADLs, it requires ADLs, so if somebody starts having difficulty handling finances, maybe we should be worried about it. But at the same time, if they've never handled finances before, then we cannot use that. Some people have never handled finances. Their husband handled finances. So, the wife will say, I never handle finances. So we cannot use that. What about ADLs? What is the first thing that could go among the ADLs? Anybody knows what is difficult among the ADLs? Activities of daily living. So basically activities of daily living, bathing, dressing, toileting, transferring.
Personal hygiene.
Sorry?
Neglect of personal hygiene.
Yeah. So in other words, they cannot shower. So showering or bathing is to do among all the ADLs. Because food, it requires one function, like toileting. As long as you can transfer, you can toilet. Continence also same. Feeding also same. But when it comes, dressing may require some help. But bathing requires everything. They have to transfer. They have to change the clothes. Like there's so much in bathing that most of them end up neglect, because they cannot shower anymore. All right. So this is the screening test. And this is used in palliative, it's used in geriatrics, it's used even in like basic clinic. Anybody who's above 65 can be screened with mini-cog. So mini-cog is basically mini cognitive test, where they have a clock. Okay, so there's a clock and then there's a few words. So the words are, for example, you can say apple, beetroot, carrot. So those are 3 words. You tell them the words, ask them, in the meantime, you ask them to remember the words, and then you ask them to draw a clock. Now, I don't know if anybody has seen this clock. I don't think I have a picture of it. It'll come in the next case presentation. I'll show you the clock. I think it should be there. Basically, there's a clock. You have to ask them to draw the arrows on the clock and also give a time, like the numbers 1 to 12, and they have to also give the time. So you tell them, okay, can you draw a clock with the numbers on it, with the arrows, and also showing a time of 11 a.m., 10 minutes from 11, like for example. So there's a 3 parts of the clock which needs to happen in order to do this test. Now, it depends. Some people draw the clock opposite, so that's abnormal, So I've seen all kinds of clocks basically for this exam. And I see that patients who can recall after the clock, you ask them, okay, what are the 3 words I asked you to remember? And some people can remember 1 word or 2 words, right? So if they can recall 0 words, that comes under dementia, realm. If they can recall 1 to 2 words, but the clock is abnormal, that is more under dementia again. But if the clock is normal, they can recall at least 2 words. It's not dementia. And if they're recalling all the 3 with the clock that's normal, again, dementia is technically ruled out. If they're able to do those basic things, this is actually a very quick test. It can happen anywhere. It's a very good one. So if you do a mini cog and that's positive, then you do a MOCA, which is a Montreal Cognitive Assessment, or you do MMSE, which is a mini mental exam. MOCA is, again, it's something that is available online. Basically, it shows different areas, including executive function, language, naming, asking them to calculate 100 minus 7, asking them to draw, and asking them, naming an object, naming a pen, things like that. So it's basically a little more comprehensive assessment. It takes some time. Okay, so it's not that those are the limitations. It takes some time, it requires some education, including at least high school. And it requires some training. In America, some people are more certified in order to address that. But here, anybody can do it. So the score here, normal above 26. And MMSE is another test where if you're not educated, it's something we can use. MMSE is also available in other languages. Less than 24, that's also a dementia diagnosis. And so here is mild cognitive impairment, like if they don't have, functional impairment, and their average is like 21 in MOCA. So the bottom line is that even though you do all these tests, dementia is a clinical diagnosis. So it's a history and physical that you diagnose dementia. Okay, these tests are only to confirm the diagnosis, and this is enough, more than PET scans or MRIs or CT scans. It's a very clinical diagnosis. This is the most important piece here for diagnosis. Now, when you combine this with palliative, so when is dementia advanced? Can anyone think about an answer when it's advanced? I mean, this is a scale that is used for in America. So basically, dementia is advanced at stage 7 onwards. And this is called a functional assessment scale. In America, with the insurance, there is a actual cutoff that says stage 7C, ambulatory ability is lost. So basically, when the patient cannot walk. So in dementia, after some time, the patient cannot talk, they cannot walk, they're not able to smile, they cannot leave their head up. That is all end stage dementia. And what happens when there's end stage dementia? They cannot eat, nutrition is not happening. And so all that means that time is short. So when someone asks you, how bad is this dementia? Like, is my father going to die from dementia? Like, are we talking end of life? How do we know it's end of life? We know it's end of life when it's end stage dementia, when they're not able to talk 6 intelligible words, when they're not able to say any words that make sense. when they're not able to get up and walk, like, completely bedridden. So this is when they actually should be discussing hospice, because usually the prognosis is less than 6 months in this state. So what is the treatment of dementia here? So in order for mental function, there's actually nothing that can restore the mental function completely. What they have right now is, so we have treatment for depression, right? We have to make sure when a patient comes to you with dementia, we have to treat the depression underlying and then see if there's a reversible part of it. Because there is something called pseudo-dementia with depression, and with treatment, there is a chance of reversal. The main thing here is to avoid anticholinergics like the diphenhydramine, antihistamines. There's many medications which we'll go over, and that'll be the medication part of the 5 M's. But here, the first line is non-pharmacological. So if suppose a dementia patient goes, really having, a lot of behavioral disturbances, the first line is actually 5 to 10 milligrams of citalopram, which is an SSRI for behavioral disturbances. That is the first line if the patient is able to tolerate by mouth. Another option is Seroquel, which is also called quetiapine. And I'm only using the generic terms because I know in India it's different, but 12.5 milligrams at night. Such a low dose is enough for geriatric patients. We start very small and then we go up slowly. One of the side effects of quetiapine is QTC prolongation. So if we are in a clinic, you're monitoring this, you want to check an EKG at least once in a visit. Inpatient, suppose somebody is being agitated or with behavioral disturbances, the first line is IV or intramuscular Haldol, 0.5 milligrams every 6 hours as needed. I have seen so many patients, so many doctors and nurses telling me, oh my goodness, 0.5 milligrams is such a small dose. But usually you will notice that with the combination of non-pharmacological measures and Haldol, that's usually enough. Another thing is this risperidone. Risperidone is used for paranoia, especially in patients who are hallucinating or scared, paranoid, being in the hospital. That is another option. Also, the Haldol 0.5 milligrams have the lowest risk of QTC prolongation compared to all the other, antipsychotics. One thing we have to remember is by the time you use antipsychotics in a patient with dementia, their mortality is lower. It starts decreasing once you start using antipsychotics. So here, this is, what all the studies, basically what I have read and what we have. The summary is that mild to moderate dementia, you can use cholinesterase inhibitors. What it does is it slows the progression of dementia. So it doesn't reverse cognitive status, but it can slow the whole process. So I have seen patients on, donepezil, memantine, all these medications for Aricept and Amanda in here. But these medications are on for 10 years. There are patients like Alzheimer's that have been on these medications for a very long time. But once it's advanced, there is honestly no use of these medications because it's advanced to the point that it's not going to reverse. At the same time, we have tried our best to limit the progression, but it's still advanced despite medications. So at that point, we really have to take out medications. Very important. Suppose somebody's anorexic. Anorexic means not eating. So if somebody is not eating, donepezil actually has shown to decrease appetite. So which is very counterproductive because patients with dementia start having decreased appetite at some point, and donepezil actually can do that. Another thing is memantine can cause dizziness. So if somebody is coming in with falls, multiple falls, we really have to question, does this patient really need memantine? So there's there are options to start, the whole idea with dementia is actually to prevent hospitalization. As much as possible, if we can manage them at home, the idea that will actually prolong their life as much as possible. So when to think of hospice, we talked about it, and that's FAST 7C, which is actually a hospice qualifier here. So here we talked a little bit of delirium. So we went through the definition. There are 3 types of delirium. There's hypoactive, hyperactive, and mixed. Can someone tell me what is worse, or which one has the more worse prognosis out of the 3 types? I mean, I'm sure you've seen some sort of dementia, delirium at some point.
Hyperactive.
Sorry?
Hypoactive.
Yeah, exactly. It is hypoactive. Why is it hypoactive? Because it is misdiagnosed, it is underutilized because the patient is silent. Hyperactive patients are loud. So you see them, they make, they throw things, they're agitated, right? So we are able to control it. But hypoactive, most of the time they are flat, they don't speak, they don't talk much. And so what happens is you're missing an underlying diagnosis there because there is something medical going on. So we really have to figure out what the baseline is. So most of the time, so what is AIDA, right? So we can talk about AIDA, which is basically, there are 4 things in dementia. So one is altered mental status. In the definition of, in delirium, In delirium, there are 4 things. AIDA. A stands for altered mental status. I stands for inattentiveness. I should have made a slide here. 1 second. I don't know if I have a slide for this. 1 second. Sorry. So basically, yes, inattentiveness, decreased concentration, and acute. Exactly. So it's acute, acute inattentiveness, decreased concentration, and altered mental status. So for these 4 things to meet, okay, which is what you use a CAM assessment, which is called confusion assessment method, all that will show you whether this patient has dementia with delirium, whether the patient has delirium. What are the causes of delirium? So I basically made a mnemonic here. Basically, delirium, the causes are, D for drugs, E for electrolytes, L for lack of drugs like withdrawal, I for infection, reduced sensory input, intracranial disorders, urinary and fecal disorders, myocardial and pulmonary disorders, so like hypoxia and things like that. So any of this can literally change the mental status. Most common that I've seen with elderly patients is actually urine infection, and they can come in with hyperactive. Patients who come in with pneumonia, they're mostly hypoactive. So each disease can have a different type of delirium. The first line treatment for delirium is non-pharmacological, which means we have to talk about how to calm them down. So things like, what are non-pharmacological? Non-pharmacological are frequent familiar presence. So having someone who they know at the bedside really helps their mental status. Having light in the room is another thing that helps. Having, some activity in the hospital, like suppose they're admitted in the hospital and they're sitting in a dark room and they have no activity and they're staring into the wall, they're going to go into delirium and it's going to get worse. Okay. So what you need is to reorient them. So when someone is telling you it's 1994, you tell them, actually, it is 2024. So you reorient them every single day. And that actually makes the most difference in delirium. If you're not able to reorient them, if they're a harm to themselves, or if they're an issue creating trouble for everybody else, like in the sense, safety issue, then you use medications. So those are the times when you start using medications for delirium, when there is a harm to self or others. And the biggest thing, in delirium you want to avoid is restraint. So a lot of times patients are held down, they're tied up. All that actually has shown to increase delirium. Now we'll go into the next M, and that is mobility. Mobility is basically function, physical function, including gait, balance and fall, and how to prevent that. Okay. So what is a fall? Fall actually is unintentionally coming to rest on the ground or other level, not due to overwhelming intrinsic or environmental cause, and without loss of consciousness. If somebody fell because they lost consciousness, that is not a fall, that is syncope, right? So it's very important to identify what is a fall and what is syncope, and different types of fall. There are mechanical falls. Mechanical falls means they tripped over a wire or tripped over something and fell. Whereas there are other falls like a bagel, or some patients say my legs gave out, but they didn't lose consciousness. That's a weakness in the leg situation. Another person may say I felt dizzy and then I fell. That's a different type of fall. So you have to figure out what the fall cause is in order to identify so that you can get the right treatment. Very important, because 30% community dwelling adults over the age of 65 and 50% in long-term care will fall every year. So that is the statistics, and that is very high. Unintentional fall is the fifth leading cause of death in elderly. People can die from falls, right? There's high risk of falls. What is the highest risk of fall? It's a previous fall, the highest risk. So if somebody has fallen, there's a very high chance they can fall again, right? It's also the leading cause of SNF placement. SNF is basically skilled nursing facilities, like, rehab, nursing home situation. Because of multiple falls, they can't be managed at home, right? So falls actually, if you've met a patient who has fallen, you will see that they're very scared to fall again. And there's this fear of falling, right? And so there's also depression, isolation. They don't move much. They don't walk much. They lead to disability and even death. So it is very, very significant. The prevalence of falls, this is specifically in the United States, but I'm sure in every part of the world, it has been increasing every year, and really need to figure out why. So how do we assess falls? The first thing is history and physical. Again, history and physical, what is the main thing here? So how do you assess fall risk? When a patient comes to you, you ask them, how many falls have you had in 1 year? Or you ask them, how many falls have you had in the last 6 months? This is a part of geriatric assessment. What are the conditions they have, the chronic conditions, what medications they're on, what is their functional status at baseline, meaning do they use a walker, do they use a cane, which side they use the cane, do they have a wheelchair? Those are the meaning of functional status. Do they get out of bed on their own? Do they eat on their own? These are all part of fall assessment. Substance use is also very important. Do they drink alcohol? Elderly also drinks alcohol, so it's important to assess that. Very, very important. One of the most important things in fall assessment, I check this on every single patient of mine, is orthostatic vital signs. So what are orthostatic vitals? Patient is supine and then go up to sitting, a drop of 20 mmHg, either from supine to sitting or from sitting to standing. So you're checking the blood pressure in 3 different positions, and you're identifying if the blood pressure drops more than 20 systolic. And also, you also see the heart rate. So as soon as you do this very quick bedside physical exam, you notice that they are dehydrated, or they're on too much diuretics, or they're on too much medication, right? So we can actually make changes to medications with this physical exam. Sometimes they need fluids. And that could be the simplest reason for fall. The other thing is visual acuity. Some people are not wearing their glasses, or some people need an eye check. Another one is like musculoskeletal, which is, sorry, I'm having a lot of disturbance. 1 second. Just wondering if we can mute. Okay. All right, so there's musculoskeletal and neuro exams. Things like patients with Parkinson's, right? So Parkinson's patients, with a high risk of falls because they have gait instability. Stroke patients have weakness on one side. Neuropathy patients don't feel their legs. So diabetic neuropathy, very common risk of falls. Gait assessment, which we talked about, what do they use? Do they have an emergency call device? Like if they fall, how do they call? Like can they call somebody? Is there somebody, they'll be lying there. And most of the times patients are seen after a while. Also have to do cognitive assessment and dementia, assessment because these patients could have undiagnosed dementia, and that could be the reason they are falling. So it's very important for that assessment. So this is something called timed up and go test. Timed up and go test is called TUG, in other words. And what we do is, so we have a stopwatch. You stand next to the patient. The patient is sitting in a chair, okay? And you ask the patient to stand up from the chair, walk on a line in front of you at a normal pace, turn, and walk back to the chair at a normal pace and sit down. And this is just like 3 meters. We're not walking long, just like a little bit. So, and then you assess the time. More than 12 seconds, 12 minutes, I would say, actually, 1 second, is 12 minutes is actually abnormal. If this is the case, so, 1 second, I'm so sorry. It's actually not minutes, I'm sorry. I just had a very bad night shift yesterday, so apologize for the mistakes I'm making. It's 12 seconds, okay? It's 12 seconds, not minutes. It was like that, minutes doesn't make sense. Okay, so it's actually 12 seconds. So it's hard. Like if you think about it, you have to get up, you have to walk a little bit, turn, go back and sit down. But that's also an easy assessment to measure whether they're a high risk of falls. Now, above 12 is not immediately high risk. Above 12 is abnormal, but it's not immediately high risk. High risk is about 30. And we'll do a case where I'll show you there's a risk of falls. But patients like Parkinson's, they have difficulty turning, they have slow shuffling gait, there's no arm swing. All this is like something you can check off in this assessment. Okay, what are the tests that we do for falls? We do EKG, electrolytes, thyroid, B12, vitamin D. If they're on digoxin, you have to check a level. You do X-ray, making sure there's no fractures or pain anywhere. Bone densitometry, because if there's osteoporosis, but it does affect the outcome. CT scan of the head, making sure there's no subdural hemorrhage. Echocardiogram to make sure there's no heart failure. EEG to make sure they're not having seizures. And then there's the vestibular testing. Excuse me. Vestibular testing is to assess what? Vertigo. To make sure they don't have like benign postural vertigo. So how do you modify the risk factors here? So there are a few modifiable risk factors, and there are some that are non-modifiable. Okay, so the extrinsic fall risk factors are the ones that we can modify. For example, footwear. Diabetic patients have to have the right amount of the right footwear. Very, very important. They should not be walking barefoot at home. Home hazards, making sure there's not many things around the house, clutter, all those kind of things, like they fall just by walking in the house. Improper use of assisted device, that's where we come to physical therapists, that they tell us how to use a walker, how to use a cane. Then the eyeglasses, new glass prescriptions, making sure they don't drink, things like that. These are all, the extrinsic fall risk factors which are surrounding them. So the environment matters. Whereas intrinsic is the part of the disease itself or the body itself, which, is based on the treatments and the medications. This is also one approach for falls with the factors like you have like their socks, shoes, their toenail, musculoskeletal, bowel and bladder, cardiovascular, medications and cognition. So it's just a toe to head approach. So this is the management which we talked about. Some things that are very important here. Okay, so we talked about fall means you have to identify the reason for fall, treat the cause, and then also treat the pain. Some patients have so much pain that they can't walk, right? So we have to treat the pain, right? Very important here is physical therapy, occupational therapy. I know there's a shortage of PTOT, but it is the most important thing to help for falling. Like, they need to help to strengthen their quadriceps, strengthen their back. Like, DME is durable medical equipment, making sure they have the right durable medical equipment to prevent falls. Deprescribing is huge. I think the one key point in this entire lecture, if you have to take away, is top benzodiazepines when it comes to patients with falls. Benzodiazepines like lorazepam, Ativan, or like Xanax, or like any of those medications that actually can be used to sleep at night can increase the risk of falls at night. Patients, wake up confused and there's just so many side effects with benzodiazepines. There's sedatives, antidepressants, antipsychotics. One very easy thing to do is for patients who are on water pills, like diuretics, minimize the dose at night. So make sure that they don't take furosemide beyond 4 p.m. because then they wake up in the middle of the night to go to the bathroom and fall. So then the other thing is environmental, making sure they have a bedside commode, if they cannot reach the bathroom, like furniture, lighting, bath mat, proper footwear. These are things that are, available, easy to change. Ophthalmology, like if they have cataract, they may need surgery, they may need glasses. Hearing aids, very important if they cannot, we have to do a hearing assessment at least once in a year. Cardiac, if there's a syncope, then pacemaker, osteoporosis treatment, anticoagulation. So very important questions. So if somebody is, has a history of atrial fibrillation and he's 80 years old and, his CHA2DS2-VASc is high, would you recommend anticoagulation or no? I mean, it's a high risk of stroke without the anticoagulation, so I'll give you that for sure. But would you recommend if somebody is falling or, I don't know if anybody's answering here, but let me see. Chat. I have some questions. Okay. All right. So this is a very controversial, but also tricky question. So here's the thing. Does anticoagulation increase the risk of falls, or does anticoagulation increase the risk of brain bleeds? Sorry, I'm going to go back again. So the answer to that is actually, the anticoagulation does not increase the risk of falls. Anticoagulation does not increase the risk of intracranial bleeding. It increases the risk of bleeding in the gut. It increases the risk of bleeding elsewhere, but there's studies that shows it takes about 300 falls per year. I don't know how they even studied this, but to cause subdural hemorrhage. What anticoagulation does is protects you from a stroke, right? And it doesn't cause a bleed. What it does is worsens the bleed, right? So if there's already bleeding there, if somebody has a subdural hemorrhage, or if somebody has a subarachnoid hemorrhage, we would not do anticoagulation on them. But if somebody has a high CHA2DS2-VASc score, very high risk of stroke, a stroke is debilitating. Bleeding in the gut can, unless it's continuous bleeding, until it's somebody who's, having so many side effects to bleeding, then it's a discussion with the patient and you obviously can stop it. But what I'm saying is that somebody who has never had GI bleeds, somebody who has atrial fibrillation, highly functional person, they actually should be on anticoagulation for atrial fibrillation because the last thing you want for them is a stroke. So the morbidity of stroke is much worse than a bleed. So this is actually studied, and this is actually the recommendation so far. I mean, hopefully it doesn't change, but so far this is the recommendation, is to continue anticoagulation on patients who are elderly in order to prevent the risk of stroke. Okay. Okay, so the one last thing there was CBT to address the fear of falling. Most of these patients have a risk of falling, like a fear of falling, sorry. This is a home safety checklist. I think you should get the PowerPoint so you can see what it can do in order to make sure patients are safe at home. The next thing is medications. Okay, so medications, now just a few more slides for the next few topics here. So the third M is medications. What we can do and what's called polypharmacy, how do we deprescribe, what is the adverse effects? Obviously, we cannot go through the entire topic, but here I am trying to minimize or summarize geriatrics in 1 hour. Okay, so one thing about medications before we go to the fourth M is less is more in geriatrics. Okay, if we can cut down medications that are unnecessary, one, the compliance will increase. Two, we're decreasing side effects. Elderly patients are more sensitive to medications. They're more sensitive to side effects of medications. And, there is also something called Beer's list. I can put it in the chat. It is called Beer's list. It's something that we can look it up whenever you have a chance, but it's a list of medications that you have to be very cautious about when we use in geriatrics. The fourth M is multi-complexity. So multi-complexity is something that it describes the entire person, with all the conditions together, and also adds up the entire mind, mobility, medications, and what matters most. What matters most is actually advanced care planning and what the goals of care are for this patient, and each patient is different. Okay, so in multi-complexity, I'll just go through very quickly a few conditions that actually make a difference here. All right. I will address the questions as soon as I am done with my lecture. Okay. So in diabetes, what is the target A1C for an elderly patient? So healthy elderly, it can be 7 to 7.5. But an unhealthy, multiple comorbidities, patient who is going towards palliative care, end of life, the target is 8, which is a very big difference between like 7 and 7.5. So we do not have to be tight with these patients. For patients with blood glucose less than 200 is ideally the goal. There are trials like Accord and advanced trials. They're older patients with long-standing diabetes. What we are saying is we don't want to cause hypoglycemia because that will increase the risk of falls. In hospitalized patients, the ideal goal is less than 180. Insulin is used if patients have more than A1C of 10%. You want to avoid liberide because there's a high risk of hypoglycemia. If the patient's creatinine clearance is less than 30, or even if it's less than 45, you don't want to start metformin. And if patient's end of life, suppose somebody's end of life who's a diabetic, right? I'm talking somebody who's actually dying. We are not going to check blood sugars at that point. We're going to minimize the finger sticks. We're going to try to once daily insulin instead of doing mealtime because they're not eating, right? Or minimal. So I would avoid hypoglycemia in elderly. Basically, that's the point here. Hypothyroidism, elderly patients, TSH can be up to 7.5 is normal. And we're talking about corrected. What happens with overcorrected hypothyroidism? Is anyone able to? This is a medical question. Sorry, it's a very clinical question. So it's actually osteoporosis. So what happens with overcorrected hypothyroidism? They give them levothyroxine, and one of the side effects of overcorrected hypothyroidism is osteoporosis. You're actually worsening their bone damage. Another one with cardiac patients. So atrial fibrillation at 6 gram dose. Any of these doses, it has to be lowered. Especially if the age is more than 80, weight less than 60 kgs, and creatinine 1.5. The statins, okay, so if somebody is 90 years old, would you start a statin on them? You don't need to. Why? Because the time to benefit is 3 years. It takes at least 3 years to see benefit from statins. Unless they have an acute stroke, unless they have like a stent, or if there's some reason, very strong indication for a statin, there is no benefit of trying to control their cholesterol at 90 years old. So it's very important. Like these are, I know they say, it sounds a little bit funny, but this happened. This is real life. End stage for shortness of breath, okay, so what is end stage heart failure or what is end stage lung disease? When they are short of breath at rest, despite all maximum medical therapy. That is when we say it's end stage, and that's when their prognosis is poor. Okay, the fifth M is what matters most. So this is basically what matters most to the patient. Like I've had so many goals of care discussions with elderly patients. Some patients don't like to talk. Some patients say, I want to golf at the end of my life. I want to drink a beer at the end of my life. Like they say all random things, but that's not the point. The point is if they know the time is short, if they know that the first thing is to address like, okay, there's a way to address this, right? So the first thing is to ask them, what do you know about your illness so far? What do you know about it? Like, tell me what you understand by what's going on. Those are the words you need to use. Even in the Indian context, you can always ask these patients, what do you understand? Many patients don't understand what's going on, right? So it's hard for patients to make decisions without understanding what's going on. A lot is on the doctor. So in order to help them help us, what we need is make them understand what's going on as much as possible. I mean, sometimes it's not possible, but the next step is to find out if they know their prognosis. Has anyone talked about prognosis to the patient? If not, ask them, do you want to know the prognosis? Is that something you want to know? Do you want to talk about it? Do you want to know how much time is left? Will that be helpful? And then after you ask that question, the next step is if they say yes, and if you give them a prognosis of less than 6 months or even like a few days or weeks, the next step is ask them, now that you know the time is short, what's important to you? It's as simple as what is important to you at the end of your life. And if you can get that far and figure out what's important, then most of the time it's like family or, faith, some people are spiritual, right? They say, different types of religion comes up, right? And so family, friends, some people say, I just want to be alone. I mean, all kinds of things come up at the end of life. And so the next and the last step is once you have addressed their goals, it's to see how to align these goals and how to align our recommendations based on their goals. I think we will have more discussions in this course about how to address advanced care planning, but that's something that we really need in geriatrics. Okay, so what is the scope of geriatrics? And what's the width of this here, right? So I can tell you what happens here. And what that means is not every hospital has geriatrics. The current hospital I'm working does not have geriatrics. But in Mount Sinai, these are the models of care. And it's just something that can be implemented anywhere. But it takes a lot of effort, coordination, money, all of it. So, but here are some models. Okay, there's outpatient, which is this simple geriatric clinic. It can be affiliated with the palliative care clinic. So sometimes there's integrated options. There are these complex care management. It's called Align. It's just an age, life, innovation, goals, and needs. But it's just the complex care management. When patients are extremely complex, they need a different care team. Acute rehab, subacute rehab, long-term care. So these are the three different types of nursing homes, which we call, So what is a nursing home and what is a rehab? They're two different things. They're not the same thing. So rehab is where there is some physical therapy. Different types are there: acute rehab, subacute rehab. In acute rehab, they tolerate minimum 3 hours of physical therapy. For example, patients with a stroke. So patients with a stroke, or maybe a traumatic brain injury or something neurological, they need minimum 3 hours of physical therapy every day. And there's a physician who comes and assesses the patient every day. But a subacute is less than 3 hours. They have nursing care, but the physician is probably once a week. And there's also the long-term care, which is not rehab, but it's more like a house, more like a stay. Like that's an actual nursing home where there's some independent activity, like they're able to do some areas. Very important to have geriatrics and emergency departments, like, if you can have that, some sort of geriatrician. The other thing I want to bring up is MACE. So we had something called MACE. It's called Mobile Acute Care of Elderly, where there's a team just for geriatrics, meaning there's a geriatrician, there is a physical therapist, occupational therapist, a pharmacist, maybe medical student, resident, fellow, and our aim is to make sure that the elderly patient is taken care of, and it's a separate thing. So this actually has studies, research, where they have shown to decrease hospitalizations, decrease morbidity and mortality. So we try to, this is how we know it's an age-friendly hospital, if they have these units. There's also something called home-based palliative, hospice models, palliative care units. So these are the ideal geriatric team I was talking about. Again, this is a dream come true if this happens. It's very difficult to make this team happen, but I just want to make sure that you all know that there are teams like this that exist, and it is possible to make it happen. All right, so how to think like a geriatrician. These are the ways that, these are like 5 steps, which I would say is basic. But I'm going to do a case presentation after this, talking about all of this, kind of integrating everything. But this is a basic evaluation for geriatric in a clinic or in a hospital setting. In medical students have these pocket cards nowadays for geriatrics. They have the 5 M's in order to help them understand what it is, and also to get better history and physical. I think this is something we should print in medical school and which should be given to other students. Okay, so these are my references, and I would like to go into the case presentation, but before that, I don't mind taking a few questions. Thank you.
Thank you, ma'am, for this session. You have explained this 5M in detail. I think our participants is very clear about the 5M now. So, ma'am, can we, before case presentation, can we see some of the questions we got in the chat?
Yes. So I want to address, so there's a question here, are screening tools for diagnosis of dementia delirium be used in the Indian context? And the answer is yes. Mini-cog can be done by anybody. You can tell them 3 words in Malayalam to remember. You can tell them 3 words in Hindi to remember. You can ask them to draw a clock. We can show them, like, even, how a clock looks. But the idea is to see if you're able to draw it and able to write the numbers. You can do MMSE. MMSE is a mini mentor. They have languages, here there is a Spanish MMSE. If we can translate the English MMSE to that language that we need, definitely can be used in Indian context. It just takes a visit. So when you call them, you have to call them specifically for this visit in the clinic. Otherwise, in the hospital, you'll have to take some time. It may take about 10-15 minutes. So that's about, yeah. And then there's another question. Advanced dementia in the Indian context is mostly managed at home. Administration of medication is a problem, particularly in patients' combativeness to advise medications which can be safely administered at home via alternative routes. Yes, the medications that we can use, you can also use PO Haldol, like oral Haldol. If they have, it depends on if they're able to swallow or not. Like, obviously, if they're not able to swallow, it's very difficult to administer medications, right? So if you're able to swallow, you can use things like we talked about, quetiapine, Haldol, oral options. If you have nurses who can help you at home, right, depends on the home situation. If you're able to get nurses or some sort of home-based palliative nursing, then you can use, subcutaneous. You can use even oral, like if you need oral morphine, okay, like for morphine for pain and everything, you can use liquid by mouth. So there are other ways. So just to make sure, I understand. So anticoagulation does not cause brain bleeds. So we actually can use anticoagulation. It only is if patients have or had brain bleeds, then we stop anticoagulation. So that's the biggest misconception in geriatrics. I know that's shocking to everyone, and I was shocked when I heard it myself, but it is true in practice. And yeah, many geriatric patients will have polypharmacy both disease modifiers. Like, how can we optimize prescription guiding falls? I would say if you can have a med reconciliation. So basically, you ask them to either bring their entire medications with them when they come. You see the medications yourself. Is there duplication? Sometimes patients are on lisinopril and losartan. Sometimes patients are on 2 types of beta blockers. Sometimes, so duplication is very, very common. One doctor prescribed this, another doctor prescribed this. Easy. It's easy to take out, and that's an easy prescription. Stop and start. So that's another technique where, if you're stopping a medication, either we can prescribe less, take away a few. I think in the case presentation, it'll be more clear on what we can take out, and we can go more on that. But if the patient's prone to falls, would you continue anticoagulation? This is a very difficult question, honestly. So really depends on what kind of falls. Are we saying that if it's a Parkinson's disease patient, or if the patient is prone to falls and has had bleeds before anywhere, like face bleeds or GI bleeds, I would not continue anticoagulation. So it's just like, it's really a risk-benefit ratio all the time. But if it's an atrial fibrillation patient, and if they cannot use anticoagulation, at least they need aspirin. It has to be something to prevent a stroke, basically. Fearless, we talked about, yes, and these are the medications to avoid in elderly. If TSH is more than 10 and TH54 normal with no symptoms, any treatment, yes, treatment will be needed. So there is something called subclinical hypothyroidism. And I think there are like 3 values that are required. So if patients' TSH is more than 10, they do need treatment. Second, just put into autostrub. Yeah, so they do need treatment. Okay. Oh, no, 1 second. Sorry. Okay. Can the screen material be available to group? Yes. Okay. How long are the medications and recommended? So it's usually in the stage of moderate dementia. So once they start, so mild and moderate, throughout you can use medications like memantine as long as there is no side effects. When it starts becoming advanced, you can take it out. It's difficult to take it out at the end because families think that it has made them alive for this long. It's really not true in advanced dementia anymore. So I would talk to family and discuss whether it's okay to take it out. How to assess MCI in illiterate patients. So very important for mind cognitive assessment, right? The MoCA will not help there, right? The MMSE can be used even in illiterate patients, but at least we can use the mini cog, to see if there's, and also history physical, we'll have to depend on. Can olanzapine be used instead of quetiapine? Yes. Olanzapine is used more for patients with decreased appetite and decreased and behavioral disturbances. So olanzapine is an antipsychotic that we use 2.5 milligrams at night for decreased appetite and for behavioral disturbances. Quetiapine does not have any effect on appetite. So it really depends on what you're looking to achieve here. Regarding polypharmacy duplication medications common, especially in rural Indian scenarios, as people sometimes can't understand what's written so small. Yes, it's common even here. So it really is the same. All right. I hope I've addressed all the questions, and
Yes,
I
ma'am.
was
Yes.
wondering if I can go into the case presentation now.
Yes, ma'am. Yes, you can move on to the case presentation. For the
Great.
participants, this will be a model presentation from next session onwards. On among you will be presenting the case. Okay. Okay. Over to you, ma'am.
I have less time to go, so I realize that this may take some. Try to get the case presented in like 5 minutes. Can you see my screen?
Ma'am, your voice is breaking in between. Rosmy, it was not clear.
I'm just making sure everybody can see my. Okay.
Ma'am, your voice is breaking in between.
So now let me just screen share the. Okay, can you see my screen now?
The screen
Yeah.
is visible, but it shows only the case presentation. Case presentation.
Yeah, that's it. That's it. Yeah, I'm looking for case presentation. Yes. Okay, perfect. All right. So we have Mr. X, 70-year-old male. There's a diagnosis of vascular dementia, recurrent falls, hypoactive delirium, urine infection.
Ma'am, sorry to interrupt, but the template just shows only the case presentations and not the actual case presentation.
Oh, okay. One second.
Now it's visible.
Is it better?
Yeah.
All right,
Perfect.
perfect. Okay, sorry for that technical issue. Okay. So we have Mr. X, who has a diagnosis here of vascular dementia, recurrent falls, hypoactive delirium, urine infection. This is just the overall diagnosis with patients coming to the hospital. The relevant previous history has had CVA here, we call it stroke, basically 2 years ago. Coronary artery disease, status post, a stent that was placed 2 years ago. Atrial fibrillation is on apixaban, which is the anticoagulant, 5 years ago. Has been on it for 5 years. Hypertension for 10 years and diabetes for about 10 years. So history of presenting illness, he's a 70-year-old male with a history of stroke, coronary artery disease, hypertension, hyperlipidemia, brought in by the daughter with progressively worsening memory loss, difficulty doing his daily activities for the past 4 months. He has had 6 falls in the last 6 months and has had increasingly been progressively weaker. He's able to eat food but has decreased appetite, and past 2 days he has not eaten any food and is confused compared to baseline. He uses walker to walk after his previous stroke. The past medical history is as above, and family history has a history of coronary artery disease, hypertension, hyperlipidemia. So with regarding functional assessment baseline, that's the first thing you want to address. Okay, so you have the ADLs and IEDLs. He's not able to bath. He's able to dress, toilet, walking, yes, feeding, okay. Transferring is no. Regarding his instrumental activities of daily living, he's not able to do housework, not able to catch a bus, driving, cooking, shopping. He's not able to make it to his appointments. He's able to take his medications, but not able to do finances. So this is an easy assessment of functional assessment. We need to have this kind of template all the time. Social assessment, very important. What is the marital status? It's important to know the marital status because you need to know what the support system is at home. So this patient is married, has about 5 children. Do you have help at home? Yes. Is it sufficient? Native language is Malayalam. Type of house independent stairs are present. DME is durable medical equipment. He says yes, and he uses a walker. Help hearing aids, yes. Glasses, yes. How many falls in last 6 months? He's had 6 falls. He's had urinary incontinence. Last bowel movement is not past bowel movement in 4 days. He has weight loss. He is not a smoker, not an alcoholic. He needs assistance with the level of independence. It's partially, I would call this partially independent. Do you feel sad or depressed? No. Have you lost pleasure in activities? No. So those 2 questions are depression screening. It's also called PHQ-2 testing. Do you find it difficult to fall asleep or stay asleep at night? And that the answer is yes, that is insomnia. So medication history. So this is what somebody asked about, how to assess, which medications, polypharmacy, duplicates and all. So you want to write the list of medications down somewhere. So patient is on apixaban, about 5 milligrams twice a day, aspirin, baby aspirin 81, ibuprofen 600 milligrams, for example, like every 8 hours, lorazepam, which is a benzodiazepine to sleep at night, vitamin C, multivitamin, amlodipine, which is blood pressure medication, losartan, blood pressure, metoprolol, short acting, atorvastatin, metformin, pantoprazole. So is there polypharmacy? Ideally, above 5 medications is actually polypharmacy, but more polypharmacy is just more than the number. So just a quick question. Do you see any duplication of medications here? Sorry, I'm going very
Yes,
fast
there
because the
is.
time is short.
There
Yeah,
is.
go.
There
Which
is.
one?
Antihypertensive. You can even include the multivitamin.
Yeah. So antihypertensives, ideally, because this is a patient with coronary artery disease, there are 3 different types of blood pressure medication. So it's okay, but you're right, it's too much. But definitely multivitamin and vitamin C. I mean, you'll find patients coming in with all kinds of extra vitamins, and this is called polypharmacy, and they don't take the actual medications that they need to take. So, all right. So what are the exams? So he's a very flat affect. He's thin. He's BMI is only 13, which is very low. He's actually malnourished. He is having a fever. Blood pressure is 90 by 50. SpO2 is 99%. He's breathing okay. Pulse is 55. Orthostatic vitals are positive. So it is positive. Pickle is no. Skin is dry. Dentures are negative, and there is no pain or pain and score. Does anyone know what pain and score is? I don't know if I've assessed that.
Pain
So
assessment in dementia. It's
perfect. Yes, there we go. That is what it is. Pain assessment in dementia. So basically, they are non-verbal signs of pain. So when dementia patients cannot talk, you have to see, are they grimacing, frowning? Are they crying? Are they yelling, screaming? These are all signs that patient is in pain. So pain and score is 0. Now, physical exam, mini cog. So in this patient, he was able to repeat the 3 words. He was able to draw the clock with the arrow with 9, 10, with correct positioning, 12, 3, 6, 9, and no duplicate numbers. I'm sorry, he was not able to. I'm sorry, it was not possible. Apologize. And he was able to repeat only 2 out of the, or recall only 2 out of the 3. So his mini cog is positive. It's 2 out of 5. Systemic exam, heart is normal, respiratory clear, abdomen normal. Systemic exam in CNS, his timed up and go test is 30 seconds. His gait is wobbly. Balance negative, Romberg's is negative. But strength wise is like, I would say 4 out of 5. I'm sorry, 1 second. 4 out of 5 altogether, like generalized weakness. Okay, I didn't write the number down, but it's 4 out of 5. For investigation, I'm just going into the abnormal ones. Hemoglobin is 7. B12 is 150. Vitamin D is 10. Everything else, thyroid, ammonia, liver function, renal function, electrolytes are all normal. In falls, because he had 6 falls in 6 months, CT brain is negative for a CT subdural hemorrhage, and MRI brain shows the previous stroke, but nothing acute. What is the treatment given here? So, couple of things. One is the patient clearly has, I didn't tell you the MCV, but the MCV was high, and also had patient had severe vitamin B12 deficiency. So we started vitamin B12 injection. We started PO vitamin B12. Also have to assess for intrinsic factor like pernicious anemia and things like that, and malnutrition. Medication reconciliation. So I have a question. What else we can take off? What causes vitamin B12 deficiency here? I don't know if anybody is able to see this again. Sorry. I just went back.
Metformin.
Yep. Metformin. And actually even pantoprazole can cause hypomagnesemia. It can basically reduces absorption, right? Pantoprazole. So the real question is, does this patient need pantoprazole? Some patients are on pantoprazole forever for no reason. Like if there's no reason for pantoprazole, take it out, Obviously, if he's had GI bleed, the patient is on aspirin and Eliquis. Most likely this patient's pantoprazole is because of GI protection, right? To protect the patient from bleeds. So it's again, risk benefit question mark. Metformin is not, it's a diabetic, but you need to know what the A1C here is. If the A1C is 10, the patient is, if his patient is on insulin, you don't need metformin here. So really, I didn't put the A1C in that pickle. Yes. Sorry, that's just the Indian, what we learned in medical school. Pallor, ictus, cyanosis, clubbing, lymphadenema. Yeah.
Patient is on 3 antihypertensive when blood pressure is
Yes.
also low and heart rate is also low. He has
Exactly.
got hypertension.
Exactly. So we want to take out what? We want to take out metoprolol short acting. So the short acting ones are worse because they actually drop the blood pressure and their heart rate. You want to reduce it to the lowest long acting possible. Patient is a cardiac patient, would benefit from beta blocker in the long term. So ideally, I would start metoprolol 12.5 XL. If that is an option, that's what we do here. I'm just telling you what we do here. Losartan is really like, does the patient need? Like, what is the ejection fraction here? Like, is it like a low ejection fraction? Do they need ACE inhibitors, ARBs? Do they need that? Really have to question it. Again, the lowest dose, 12.5. So basically half of the actual pill is what we give these geriatric patients. Amlodipine can be completely discontinued. Patients orthostatic. Vitamin C can be discontinued. What else is there? Patients having 6 falls in 1 year. 6 falls in 6 months. There's lorazepam at night. We have to start tapering that. We can use things like melatonin for sleep. You can use things like Remeron, which is mirtazapine at night to sleep. And then very important.
Aspirin and aspirin are there. Can cause bleed.
Yes. So you said aspirin and Eliquis, right? Yeah, aspirin and apixaban are not required together in atrial fibrillation anymore. So if a patient has had a stroke, apixaban or the anticoagulation takes precedence. So the aspirin can be discontinued. So this is how you shorten the list of medications for polypharmacy. Okay. So let me go ahead. Yeah. So another thing you can discontinue, very important, is ibuprofen. So what is ibuprofen? Is basically NSAIDs, right? So NSAIDs, patient is on pantoprazole, patient is on 2, anticoagulation and aspirin. Like ibuprofen is only going to make things worse. Another thing it can do is increase the blood pressure. It's just complicated for no reason. So instead, you can use exactly coronary disease. So here, I use the word Tylenol, but acetaminophen, like Dolo, we can use about 1,000 milligrams 3 times a day. This is the maximum scheduled dose that we can use in geriatrics. So in patients who are on acetaminophen, maximum we are allowed only 3 grams, not 4. 4 is in adults, which are like less than 65. But you want to see that. And I have seen, this is my schedule that I use for everybody because The Tylenol works, like acetaminophen just works, especially osteoarthritis and patients with chronic back pain, and this actually avoids the use of opiates, narcotics, use of tramadol, or use of other medications. If it's not required, we try to minimize. Physical therapy, occupational therapy. Why? Because the patient has had falls, right? So we really need to evaluate their need for durable medical equipment. Does this patient, is the patient using the walker properly? There are some walkers that have rollers on them. Patients with Parkinson's, we don't want to give them walkers with wheels on them because that actually, they can go forward and they can fall backward, right? So it's just like things like that, like what kind. You want to assess their MoCA because that's the big picture. Is this patient have dementia? So this is an example of the 5Ms, how I used it. It's a very simple example, right? How did I use all the 5Ms in this one patient? So mind, I'm doing a MoCA. This patient's MoCA was 20. He has mild or early dementia. Why does this patient have dementia? Because he was not able to do his 1 or 2 IADLs and ADLs. He was not able to bathe. He was not able to do finances. He was not able to make it to appointments. He actually had functional decline. So this is why it is actually this patient has dementia, right? Medications, we talked about deprescribing, mobility, PTOT, walkers, and all of that, multi-complexity, adjustment of the actual medical illness. You want to add intrinsic factor to make sure there's no pernicious anemia. And what matters most? So suppose he has an emergency. He's not able to make decisions. Who makes decisions for him? Who is the family member here? And the other question is code status. I know the code status discussion is just coming up in India, and I know that it is still possible to get someone to do not resuscitate, but that's a question. I mean, my grandmother died in India, and with requiring geriatric care, and I know we could get her to DNR. So if there's someone who is a very high risk of intubation, but intubation is futile, it is something to talk about with the family. So any specific points other than these 4 discussions? So any questions? Sorry, I just want to make sure I address them.
Thank you, ma'am, for this presentation. So now, if the participants have any doubt, you can ask now.
And sorry, I went really fast. There was a lot of content. You can all have my PowerPoint presentation. The case presentation is something new that we introduced. It doesn't have to be complicated. Like, it can be very straightforward and simple, what we see in a daily life. But please bring forward your case presentations, whoever, any questions or any patients, any complexities that we have, and something we can always discuss.
Are there any points which can guide us for DNR?
Yes, actually. So I am still, I think the end of the entire course, my program director, Elizabeth Lindenberger, hopefully she will join and we'll talk about advanced care planning. But to summarize, first thing I would say is never start the conversation of DNR abruptly without discussing goals first. So that's a big mistake people make, I mean, and sometimes we have to, in an emergency situation, we have to ask, like, okay, God forbid, if your heart or lung stops, and I'm saying this in English, it obviously has to be translated to whichever language we have to translate it to, but God forbid, if your lung or heart stops in an emergency situation, would you want us to do chest compressions, including, like, pressing on your ribs? That means that your ribs can fracture. Or would you want us to connect you to a breathing machine with tube down your throat and, breathing machine? And you have to also kind of tell them, like, is there a chance of recovery here? If this is a completely young, healthy individual who has no comorbidity, 60-year-old person coming in, it's important to assess the whole picture, right? But eventually, there's also a recommendation piece of code status, meaning You can ask them. Most likely they'll say, I don't know what to do. And at that point, you recommend. See, especially in an elderly patient, you say, okay, based on what you're saying, I don't know. I mean, I think I would recommend DNR because that, it would be more harm if we were to crack ribs and, do intubation and connect them to breathing machine when there's really no chance of recovery. So we have to make them understand what it actually means.
Thank you. I think it's more intuitive there. I think we'll have to go by your gut feeling.
Yes, gut, but also like prognosis, right? Overall prognosis. If somebody's just come in for example, COPD exacerbation, and it's an acute exacerbation that may require intubation, they may recover from it. Somebody with cardiac arrhythmias, their heart stops, they may recover from it. So, but if you're talking about a 90-year-old patient who has Parkinson's and dementia, not eating, no quality of life, they're not going to come out of ventilators usually. That's because of their respiratory weakness. Yeah.
I have seen patients who are 70 or even above 60. They say no intubation, don't put trials tube. So actually, I
Yeah.
support them, though
Yeah.
many may not agree with that.
No, I 100% agree with that because, in the US, we have something called POST form. So that's actually physician orders for life-sustaining treatment. And there is a form that, here the ethics is very much advanced, right? Patients have a lot of autonomy. They're able to decide so much on their own before even we recommend, right? So things like feeding tube. Would you ever want a feeding tube? Would you ever want a surgery to insert a feeding tube extra and give you artificial feeding for life? Would you ever want dialysis? Would you ever want fluids, continuous fluids, repeated hospitalizations? Like, if you were terminally ill, would you ever want resuscitation? So, like, that's actually a form which, I mean, I hope that one day we get introduced to in India also. But it is called a POST or a MOST form, very much underutilized even here. But it's something that helps these discussions happen.
Thank you.
Ma'am, we have one question.
Yeah.
In the chat box.
Okay, 1 second.
The patient.
So it's severe vitamin B12. Yes, thank you for picking that up. So I thought nobody will pick that up. So actually, vitamin D deficiency, repleting vitamin D actually decreases the risk of falls. So that is something we should do, is replete vitamin D. Almost the whole world has vitamin D deficiency. So it's an easy fix. Checking vitamin D levels at least once a year is important, but that could also supplement. Yep, that is another treatment. Thank you, Aditya.
Okay. So the time is up. So I think
somebody raised their hand. Is it okay if I answer the question? Sorry, I don't know. Somebody. Yeah,
No, I just wanted to say that, like, as the doctor had asked about the decision, no, it's more of a medical decision. The more responsibility lies on the physician to explain the condition, not to tell them that they are not making, neither the patient, kith or kin is making this tough decision of deciding for treatment or anything like that. More to be explained, like, from like, so much of practice and information we have from patient material and data, that this patient with all these conditions, prognosticating the patient's condition and telling them because of all this, the outcome may not be good. So in that is why the decision is made, not that we are blindly making any decision like that.
Oh yeah, 100%.
So this can help the patient and family to a very great extent, that no guilt exists there.
Oh, that's a very good point. Yeah, because
it's a medical decision on.
Yes.
That just I wanted to bring that up.
Yes, thank you, Dr. Radha. Very big decision this is, right? It's one of the biggest decisions that any family member has to make sometimes, and there is a lot of guilt associated with it, and we should avoid that. We should try to help them make the decision, but eventually it works together. That's very important that both patient and physician work together in that.
I think if we take it as meeting of two experts, it'll be easier.
Yes.
See,
Because the patient is, yeah, please go ahead.
the parent team physician, for example, you have a patient who is a end stage lung patient, ILD. 20 years they would have gone to a physician. Okay, that physician who has treated them for 20 years will know very well in the last 6 months that patient has deteriorated very, very badly, like 6 falls, no, 6 admissions of acute exacerbation of COPD, for example, I'm telling. Okay, so 6 exacerbations in 6 months. How the condition? They may be on 4 inhalers, 2 times nebulization, still breathless at rest.
Yeah, so that is end stage.
So there, the parent team physician should help the other team. For example, that same patient is admitted to an ICU. Okay, there if they both together help in making the decision, that is where.
Yes.
But unfortunately, in this lot of professional good relationship is required.
Yes. Coordination of care is very much required here. One of the jobs of the palliative care doctor, especially here, if we consult palliative care, they call the primary physician, they call the pulmonologist, whoever is responsible for the patient, whoever knows the patient well, we include them in the meeting. So it's very important that they hear from their primary doctor. Okay. All right.
Can I ask one question?
Yes.
If you started the patient on Haradol 0.5 milligram Q6 hourly for agitation,
IV or IM, yeah.
Yeah. So you're going on giving that injection. When you want to stop that
Great question.
agitation?
Yeah, that's a great question. So it's uses as needed, right? So even, for example, Seroquel, which is the quetiapine or the Haldol. So this is temporary. It is used as needed. If it is not going away, like suppose the patient is continuously agitated despite using multiple Haldol or that means they need further medical investigation, right? Like a dementia patient does not get continuously agitated for days. It's usually depends on the reason for agitation. So for example, a patient who's super constipated has not had a bowel movement for 4 or 5 days. You keep giving Haldol, there is no use. Haldol is only going to treat the agitation temporarily. You have to treat the constipation, right? The constipation resolves, delirium gets better, patient improves. And that's when you stop the Haldol. So you stop the Haldol when it's no longer required, basically. I don't know if I answered the question. Did you get it? Sorry.
Yes. What about?
It's not a continuous medication. Haldol is not a continuous medication. It's not a daily regimen. Haldol is short acting. It is used only as needed basis. The continuous medication that you can use is quetiapine. So quetiapine, like 12.5 milligrams every night, is used to prevent sundowning. So, for example, patients with dementia, hallucination, dementia, sometimes every evening they start sundowning, they get agitated. You can start using Seroquel. You can start, even Haldol you can use. I've seen in India 2 milligrams of Haldol is used orally. I would say these are the few options. Risperidone is also there. But, we have those few options, but that can be used daily basis.
So if the behavioral disturbance is controlled with quetiapine, and after maybe 2 or 3 weeks, again it starts happening, can I increase the dose?
Every time there is a change in mental status from the baseline, you have to reassess medically what is going on. We cannot just increase the dose. If this is a chronic condition, because behavioral disturbances with dementia are chronic. With delirium, it is acute, right? So if it's acute, You need to assess medical situation. You may have to call them back for labs, investigation, urine analysis. You need to check for constipation. You need to make sure there's nothing else coming in the picture. But if you're right, if the behavioral disturbances are chronic, yes, then you can go up on the medication. That means the symptoms are not controlled from dementia perspective. I'm just making sure you assess for delirium every single time. Like you have to make sure that you're not missing something, because then you're just going to mask the delirium.
Thank you.
Thank you, ma'am. So we will be having this dementia, delirium, these topics in detail in next session. So thank you, ma'am. Thank you for the detailed presentation as well as thank you for the case presentation. I think participants are very clear about today's session. Now the time is up. So we can conclude today's session. Over to Sangeet.
Thank you, ma'am. Thank you, ma'am. Thank you, Dr. Rosmy, for the wonderful interactive sessions. Thank you, Dr. Grishma, for facilitating the whole session. Thank you, all participants, for joining the sessions and making it interactive. Thank you. Let's see you in the next session. Bye.